What is inflammation? Inflammation is a local response of living mammalian tissues to injury from any agent. Actually, it is a body defense reaction in order to eliminate or limit the spread of injurious agent. So the injurious agent causing inflammation may be infective agent, immunological agent, physical agent, chemical agent, inert materials such as foreign bodies. Inflammation and infection both are not same. Inflammation is a protective response by the body to variety of etiologic agents, while infection is invasion into the body by harmful microbes and their resulting in effects by toxins. Signs of inflammation: rubor means redness, tumor means swelling, pallor, heat, and duller pain. And fifth sign is functional loss or loss of function, added by vigil. These are the signs of inflammation. So this is a basic thing of any inflammation: microbes entering the cell, being recognized by tissue resident sentinel cells. Sentinel cells means first cell which counteract the microbes. It is macrophage, dendritic cell, and mast cell. Then this secretes some mediators. Then recruitment of lymphocytes, monocyte, granulocyte. Then elimination of microbes by macrophage. Then release some cytokines or growth factors. Then healing and repair. This is the basic idea or basic concept of any inflammation. Disease caused by inflammatory reaction: acute and chronic. Acute respiratory distress syndrome, asthma, glomerulonephritis, septic shock. Chronic arthritis, asthma, atherosclerosis, pulmonary fibrosis. Acute inflammation. It has three major components: the allocation of small vessel leading to an increase in blood flow, increased permeability of the microvasculature, immigration of lymphocytes from the microcirculation, their accumulation in the focus of injury, and their activation to eliminate the offending agent. Acute inflammatory reaction has two phases: vascular events, cellular events. Vascular reactions of acute inflammation consist of changes in the flow of blood and the permeability of vessels, both designed to maximize the movement of plasma proteins and lymphocyte out of the circulation and into the site of infection or injury. Now the escape of fluid, proteins, and blood cells from the vascular system onto the interstitial tissue or body apparatus is known as exudation. An exudate has high protein concentration. Its presence implies the existence of an inflammatory process that has increased the permeability of small blood vessels. In contrast, transudate is a fluid with low protein content. Changes in vascular flow and caliber. Changes in vascular flow and caliber begin early after injury and consist of the following: vasodilation is induced by the action of several mediators, notably histamine, on vascular smooth vessel. It is one of the earliest manifestations of acute inflammation. Vasodilation is quickly followed by increased permeability of the microvasculature. The loss of fluid and increased vessel diameter lead to slower blood flow, concentration of red cell in small vessels, and increased viscosity of blood. These changes result in enlargement of small vessels with slowly moving red cell, condition termed as casis. As casis develops, blood leukocytes, principally neutrophils, accumulate along the vascular endothelium. At the same time, endothelial cells, are activated by mediators produced like site of infection and tissue damage and express increased level of adhesion molecules. Then increased vascular permeability or vascular leakage. It is a hallmark of acute inflammation. Contraction of endothelial cell resulting in opening of intraendothelial gaps is the most common mechanism of vascular leakage. Contraction of endothelial cells. It is elicited by histamine, bradykinin, leukotrienes, and other chemical mediators. Endothelial injury resulting in endothelial cell necrosis and detachment. Response of lymphatic vessels and lymph nodes. In addition to blood vessels, lymphatic vessels also participate in acute inflammation. The system of lymphatics and lymph nodes filter and polyses the extravascular fluid. Lymphatics drain the small amount of extravascular fluid that sifts out of capillary in the healthy state. In inflammation, lymph flow is increased and helps drain edema fluid that accumulate because of increased vascular permeability. Vascular reactions in acute inflammation, vasodilation by histamine and is the cause of edema and increased blood flow. Increased vascular permeability is induced by histamine, kinins, and other mediators that produce gaps between the endothelial cells and by direct or leukocyte-induced endothelial injury. Then increased vascular permeability allows plasma protein and leukocyte, the mediators of host defense, to enter site of infection or tissue damage. Fluid leak from blood vessel resulting in edema, lymphatic vessel and lymph nodes are also involved in inflammation. Now these are the mechanisms of increased vascular permeability. First is endothelial cell contraction. Second is contraction or mild endothelial injury. Third is direct endothelial cell injury. Fourth, leukocyte-mediated endothelial injury. And fifth, neovascularization. These are the 5 mechanisms of increased vascular permeability. Now, vascular phase is over. Now, cellular phase. Cellular phase of inflammation consists of 2 processes: exudation of leukocyte and phagocytosis. Cellular event, leukocyte recruitment to site of inflammation. The changes in blood flow and vascular permeability are quickly followed by an influx of leukocyte into the tissue. This leukocyte performs the key function of eliminating the offending agent. The most important leukocytes in typical inflammatory reactions are ones capable of phagocytosis, namely neutrophil and macrophage. So phagocytosis not only to macrophage but also neutrophil. The journey of leukocyte from vessel lumen to the tissue is a multi-step process. First is in the lumen. In the lumen, migration, margination, rolling, and adhesion to endothelium. Vascular endothelium in its normal state does not bind circulating cells or allow their passage. Then migration across the endothelium and vessel wall, migration in the tissue toward a chemotactic stimulus. Now the leukocyte adhesion to endothelium. In normally flowing blood in venules, red cells are confined to a central axial column, displacing the leukocyte toward the wall of vessel. Because of dilatation of inflamed postcapillary venules, blood flow slows, that is called stasis, and more white cells assume a peripheral position along the endothelial surface. This process is called margination. The attachment of leukocyte to endothelial cell is mediated by adhesion molecule whose expression is enhanced by cytokines. The 2 major families of protein involved in leukocyte adhesion and migration are selectin and integrin, and their ligands. Selectin are three types. L-selectin expressed on leukocyte, E-selectin expressed on endothelium, and P-selectin expressed on platelet and on endothelium. L-selectin, E-selectin, and P-selectin. Then integrin. The weak rolling interactions slow down the leukocyte and give them the opportunity to bind more firmly to the endothelium. Firm adhesion is mediated by a family of heterodimeric leukocyte surface protein called integrin. So, these are the molecules helping endothelium and leukocyte adhesion molecules. Selectin, integrin. Selectin, L-selectin, ligand is saline leu-10 or X, E-selectin, P-selectin. Then integrin. Integrin, you can remember the name of the molecule, NFA, I, MAC-I, VLA4, like this. And immunoglobulin CD31. And you can remember the name of the ligand, ICAM and VCAM. Now the leukocyte migration through endothelium. The next step in the process of leukocyte recruitment is migration of the leukocyte through intact endothelium called transmigration or diapharesis. Several adhesion molecules present in intercellular junction between endothelial cells are involved in the migration of leukocyte. These molecules include a member of immunoglobulin superfamily called CD31 or PKM1. Then chemotaxis of leukocytes. After exiting the circulation, leukocyte moves in the tissue toward the site of injury by a process called chemotaxis. The most common exogenous factors are bacterial products including peptides with N-formal methionine terminal, amino acid, and some lipids. Endogenous chemoattractants include several chemical mediators, cytokines, chemokine family, example IL-8. Components of the complement system, particularly C5a and arachidonic acid metabolite, mainly LTP4. These are the chemical mediators. Then leukocyte recruitment to site of inflammation. Leukocytes are recruited from the blood into the extravascular tissue. Leukocyte recruitment is a multi-step process consisting of loose attachment to and rolling on endothelium mediated by selectin. Firm attachment to endothelium mediated by integrin. So function of selectin, rolling on endothelium. And function of integrin, firm attachment to endothelium. Neutrophils predominate in the early inflammatory infiltrate are later replaced by monocyte and macrophage. Phagocytosis and clearance of the offending agent. The two major phagocytes are neutrophil and macrophage. You should remember the two names, not only macrophage but also neutrophil. Neutrophil also do phagocytosis. Recognition of microbes or dead cells induces several responses in leukocyte that are collectively called leukocyte activation. Phagocytosis involves sequential steps. Recognition and attachment of the particle to be ingested by the leukocyte. Then engulfment. Engulfment is subsequent formation of a phagocytic vacuole and killing of the microbe and degradation of the ingested material. There are some phagocytic receptors, Magos receptor, scavenger receptors, and receptors for various opsonins enable phagocytosis to bind and ingest microbes. Then engulfment. After a particle is bound to phagocyte receptors, extensions of the cytoplasm flow around it and the plasma membrane pinches off to form an intracellular vesicle or phagosome that encloses the particle. The phagosome then fuses with a lysosomal granule which discharges its contents into the phagolysosome. Then neutrophil extracellular traps are extracellular fibrillar networks that concentrate antimicrobial substances at sites of infection and trap microbes, helping to prevent their spread. Leukocyte activation and removal of offending agent. Leukocytes can eliminate microbes and dead cells by phagocytosis, followed by their destruction in phagolysosome. Destruction is caused by free radicals generated in activated leukocytes and lysosomal enzymes. Neutrophils can extrude their nuclear content to form extracellular nets and that trap and destroy microbes. Anti-inflammatory mediators terminate the acute inflammatory reaction when it is no longer needed. Now the mediators of inflammation. Inflammatory mediators are the substances that initiate and regulate inflammatory reactions. The most important mediators of acute inflammation are vasoactive amines, lipid products, cytokines, and products of complement activation. Mediators are either secreted by cells or generated from plasma protein. So these are the principal mediators of inflammation or principal mediators of acute inflammation. Histamine, prostaglandins, leukotrienes, cytokines, TNF, IL-1, IL-6, chemokines, platelet activating factor, complement, and kinase. These are the principal mediators of inflammation. So it are two types, cell-derived mediators and plasma protein-derived mediators. So cell-derived mediators, vasoactive amines, histamine, 5-hydroxytryptamine, neuropeptide, arachidonic acid metabolite, cytokines, IL-1, IL-6, IL-8, IL-12, IL-17, TNF-alpha, TNF-beta, interferon gamma, and plasma protein-derived mediators, the kinase system, protein system, fibrinolysis system, and complement systems. So these are the mediators of inflammation, cell-derived and plasma protein-derived. So major cytokines in inflammation: IL-1, 6, 8, 12, 17, TNF-alpha, interferon gamma, MCP1, eugastine, and PF4. These are the major cytokines in inflammation. So in acute inflammation, mediators are TNF, IL-1, IL-6, chemokines, IL-17. And in chronic inflammation, IL-12, interferon gamma, and IL-17. Now the morphology of acute inflammation. Types of exudate. First one is serous. When the fluid exudate resembles serum or is watery, that is pleural effusion in tuberculosis, blister formation in burns. It is serous. Then number 2 is fibrinous. When the fibrin content of the fluid exudate is high, like in pneumococcal and rheumatic pericarditis. So first one is serous, second one is fibrinous. Third one is purulent or suppurative exudate, which formation of creamy pus as seen in infection with pyogenic bacteria, seen in abscess. Pseudomembranous inflammation. It is inflammatory response of mucous surface, like in oral, respiratory, bowel, to toxins of diphtheria or irritant gashes. As a result of denudation of epithelium, plasma exudes on the surface where it coagulates and together with necrosed epithelium form false membrane that gives this type of inflammation its name. Then third one is ulcer. Ulcers are local defect on the surface of an organ produced by inflammation. Some common sites for ulcerations are the stomach, duodenum, intestinal ulcer in typhoid fever, intestinal tuberculosis, bacillary and amoebic dysentery, ulcers of legs due to varicose veins. Then fourth one is suppuration or abscess formation. When acute bacterial infection is accompanied by intense neutrophilic infiltrate in the inflamed tissue, it results in tissue necrosis. That is called suppuration. A cavity is formed which is called an abscess and contains purulent exudate or pus. And the process of abscess formation is known as suppuration. The bacteria which cause suppuration are called pyogenic. Then fifth one is cellulitis. It is a diffuse inflammation of the soft tissues resulting from spreading effects of substance like hyaluronidase released by some bacteria, bacterial infection of the blood. This includes following three conditions: bacteremia, septicemia, and anemia. Now the systemic effects of acute inflammation. Number one is fever. Fever occurs due to bacteremia. It is thought to be mediated through release of factors like prostaglandins, interleukin-1 and TNF-alpha. Second one is leukocytosis. Commonly accompanies the acute inflammatory reaction, usually in the range of 15,000 to 20,000 or microliter. When the counts are higher than this with shift to left of myeloid cells, it is called leukomoid reaction. Then third one is lymphangitis. Lymphangitis is one of the important manifestations of localized inflammatory injury. The lymphatics and lymph nodes that drain the inflamed tissue show reactive inflammatory changes in the form of lymphangitis and lymphadenitis. That means increase of the size of lymph node. Fourth one is shock. Shock may occur in severe cases. Massive release of cytokine TNF alpha, a mediator of inflammation, in response to severe tissue injury or infection results in profuse systemic vasodilation. The net effect of these changes is hypotension and shock. Now, fate of acute inflammation. First one is resolution. Resolution means complete return to normal tissue following acute inflammation. Then healing. When the tissue loss is in acute inflammation is superficial, healing takes by regeneration. Then suppuration. When the pathogenic bacteria causing acute inflammation results in severe tissue necrosis, the process progresses to suppuration. Subsequently, mixture of neutrophil, bacteria, fragments of necrotic tissue, cell debris, and fibrin compounds pass which is contained in cavity to form an abscess. Then number 4 is chronic inflammation. Persisting or recurrent acute inflammation may progress to chronic inflammation in which the process inflammation and healing proceed side by side. So resolution from acute inflammation is resolution, regeneration, healing by fibrosis, chronic inflammation, and suppuration. These are the fate of acute inflammation. Now chronic inflammation. Chronic inflammation is the response of prolonged duration in which inflammation, tissue injury, and attempt at repair coexist in various combinations. Cause chronic inflammation following acute inflammation, recurrent attacks of acute inflammation, and third is chronic inflammation starting de novo when the infection with organism of low pathogenicity is chronic from the beginning. from the beginning, that is infection with Mycobacterium tuberculosis. Now, morphologic features. Chronic inflammation is characterized by infiltration with mononuclear cell, which include macrophages, lymphocytes, and plasma cells. Tissue destruction and attempts at healing by corrective tissue replacement of damaged tissue accomplished by angiogenesis and in particular fibrosis. Angiogenesis means proliferation of small blood vessels. Cells are mediators of chronic inflammation. Role of macrophages. The dominant cell in most chronic inflammatory reactions are macrophages, which contribute to the reaction by secreting cytokines and growth factors and activating other cells, notably T lymphocyte. The products of activated macrophages eliminate injurious agents such as microbes and initiate the process of repair, but are also responsible for much of the tissue injury in chronic inflammation. Macrophages, like the other types of phagocytes, the neutrophils ingest and eliminate microbes and dead tissue. Macrophages initiate the process of tissue repair and are involved in scar formation and fibrosis. Macrophages secrete mediators of inflammation such as cytokines and eicosanoids, TNF, IL-1 chemokines. There are two major pathways of macrophage activation. One is classical and other one is alternative. Classical pathway and alternative pathway. Classical macrophage activation may be induced by microbial products such as endotoxin, which engage TLR and other sensors by T-cell-derived signals, importantly cytokine, interferon gamma. Alternative macrophage activation is induced by cytokines other than interferon gamma such as IL-4 and IL-13. So these are the two pathways, classically activated and alternatively activated macrophage. And these are the mediators of chronic inflammation. Interferon gamma, IL-13, IL-4, IL-1, IL-12, IL-23, and here TGF-beta, IL-10. So the effects is microbicidal action, phagocytosis, killing of bacteria, fungus, inflammation, tissue repair, fibrosis, and anti-inflammatory effects. Now the role of lymphocyte. Microbes and other environmental antigens activate T and B lymphocytes which amplify and propagate chronic inflammation. Activation of this cell is often prominent in chronic inflammatory reactions, and when they are involved, the inflammation tends to be persistent and severe. Some of the persistent chronic inflammatory reactions such as granulomatous inflammation. CD4 plus T lymphocyte promote inflammation and it causes granuloma formation. CD4 plus T lymphocyte. This lymphocyte causes granuloma. There are three subsets of CD4 plus T cells that secrete different types of cytokines and elicit different types of inflammation. Th1 cells produce cytokine interferon gamma, which activate and macrophages by the classical pathway. Then Th2 cells secrete IL-4, IL-5, and IL-13. It is responsible for alternative pathway. Then Th17 secrete IL-17 and activated B lymphocyte and antibody producing plasma cells. Other cells, you can remember the name neutrophil, mast cells. Although neutrophils are characteristic of acute inflammation, many forms of chronic inflammation continue to show large number of neutrophils. Now the granulomatous inflammation. Granulomatous inflammation is a form of chronic inflammation characterized by collections of activated macrophages, often at T lymphocyte. Granuloma formation is a cellular attempt to contain an offending agent that is difficult to eradicate. The activated macrophages may develop abundant cytoplasm and begin to resemble epithelial cells and are called epithelioid cells. Some activated macrophages may fuse, forming multinucleate giant cells. So, multinucleate giant cells formed by fusion of activated macrophage. There are two types of granulomas which differ in their pathogenesis. One is called foreign body granuloma, are incited by inert foreign bodies which induce inflammation in the absence of T cell mediated immune response. And another one is called immune granuloma. One is foreign body granuloma and another one is immune granuloma. Immune granuloma are caused by a variety of agents that are capable of inducing a persistent T cell mediated immune response. This type of immune response usually produces granuloma when the inciting agent is difficult to eradicate, such as persistent microbe. Morphology. The activated macrophages in granuloma have pink granular cytoplasm with indistinct cell boundary and are called epithelioid cells because of their resemblance to epithelia. That's why it is called epithelioid cells, look like epithelial cells. The aggregate of epithelioid macrophages are surrounded by a collar of lymphocytes. Older granuloma may have a rim of fibroblast and connective tissue. Frequently but not invariably, multinucleated giant cells are found in granulomas. These are called Langerhans giant cells. So, how the granuloma is formed? First, cell injury, then failure to digest agent, weak acute inflammatory response, engulfment by macrophage, persistence of injurious agent, T cell mediated immune response, or poorly digestible agent, then activation of CD4 plus T cell. Activation of CD4 plus T cell is the most important. Then macrophages activated by interferon gamma, and then granuloma formation occurred. Now the giant cells. Giant cells in inflammation, foreign body giant cell. This contains numerous nuclei up to 100 which are uniform in size and shape and resemble the nuclei of macrophage. These are seen in chronic infective granulomas, leprosy, and tuberculosis. Then Langerhans giant cell. First one is foreign body giant cell. Then second is Langerhans giant cell. This seen in tuberculosis and sarcoidosis. These nuclei are arranged either around the periphery in the form of horseshoe or ring, or are clustered at the two poles of giant cells. Then proton giant cells. These multinucleated cells of vacuolated cytoplasm due to lipid content, seen in xanthoma. Number 4 is Asher giant cell. These multinucleated giant cells are derived from cardiac histiocytes and are seen in rheumatic nodule. So, giant cell inflammation, first one is foreign body giant cell, then second one is Langerhans type giant cell, third one is proton giant cell, and fourth one is Asher giant cells. Then giant cell in tumors. Anaplastic cancer giant cells. These are larger, have numerous nuclei which are hyperchromatic and vary in size and shape. These giant cells are not derived from macrophage but are formed from dividing nuclei of the neoplastic cells, seen in carcinoma of liver, various soft tissue sarcoma. Then second one is Reagent Identification cells, seen in Hodgkin's lymphoma. Third one is osteoclastic giant cell of bone tumor. So giant cell in tumors, these are three types. Anaplastic cancer giant cells, rich tumor cells, and osteoclastic giant cells of bone tumor. Picture of granuloma. You can see central caseating necrosis, and these are the giant cells. These are the Langhans type of giant cells. Nuclei are arranged in peripheries. It is called Langhans type giant cells, and central caseating necrosis. And these are the epithelial cells. And at the outer surface, it is collar of lymphocytes, outer surface. These are the epithelial cells. Epithelial cells are the most important component of a granuloma. These are the inflammatory giant cells, foreign body giant cell. Nuclei are arranged in haplocyclically. This is Langhans type giant cell. Nuclei are arranged in periphery. And this is proton type giant cell. And these are the tumor giant cell. Anaplastic tumor giant cell, rich tumor cell, osteoclastic tumor giant cell. And these are the few diseases with granulomatous inflammation. Tuberculosis, we will see caseating granuloma. Leprosy, caused by Mycobacterium leprae. Tuberculosis caused by Mycobacterium tuberculosis. Leprosy, acid fast bacilli in macrophages. Syphilis, caused by Trichoderma pallidum. Caxpias disease, gram-negative bacilli, rounded or skelet granuloma containing central granular debris and recognizable neutrophils. Here we will find neutrophils in Caxpias disease. Sarcoidosis, non-caseating granuloma. In sarcoidosis, we will find non-caseating granuloma. Crohn's disease, immune reaction, occasional non-caseating granuloma. So these are the diseases with granulomatous inflammation. Tuberculosis, leprosy, syphilis, Caxpias disease, sarcoidosis, and Crohn's disease.